Hello, everybody, and welcome to the Downsized. Today, we're going to follow the continuing saga of CVS Caremark, Zepbound and Wegovy, and I'm excited to have Joe Zucchi with us. Joe, it's great to have you, man.
Thanks, Christopher. Great to be back and looking forward to continuing to keep people updated on this whole ongoing debacle.
If you don't know me, my name is Christopher Durham. I, along with my wife, started this channel. It's called Downsized, where we talk about all things GLP-1, news, what's going on in our lives. We do interviews with patients, occasional cooking videos, occasional workout videos, you name it. We do all sorts of things. I've personally lost a little more than 100 pounds using Zepbound, Mounjaro, tirzepatide, variations across the board. So this is a very real conversation. Me and my wife has lost 50 pounds. So together we've lost 150 pounds between us. So this is what we do every day, videos. And occasionally we like to have medical professionals on to talk about what's going on in the news. I will start out by saying I'm not a doctor. Joe is a medical professional, but Joe is not your medical professional. So please talk to your doctor and get a personalized approach just for you. This is all educational. So to put it, if you haven't already, take a moment and like and subscribe. So Joe, is this the third time you've been with us?
It is, yeah. We've talked about everything from just GLP-1s and anti-obesity medications as a whole, and then more recently kind of advocating for coverage for patients that are losing coverage due to various insurance issues. So glad to be back.
So go, if you like what you see here, go back and watch Joe's other interviews because we had some great conversations. So Joe, tell us a little bit about you. Give us the background on Joe and what you do.
Sure. So I've always worked in obesity medicine, very passionate about this field. I serve as the clinical supervisor. I'm a physician associate at Transition Medical Weight Loss in Salem, New Hampshire. I've done certainly podcasts, speaking engagements. I've also done different types of op-eds, kind of advocating for patients in terms of coverage for these medications, why obesity is a complex disease that deserves grace and not stigma and bias, and helping patients to advocate for why these tools are great medications and how to hopefully use them and get insurance to cover them. So definitely passionate about this, and hopefully I can help not just my patients, but other patients out there who are going through the same battle.
Cool. And how long have you been doing it?
I've worked in weight management for probably over a decade. I've worked at this position for over 6.5 years. So very much been in tune with this and followed along for many years. So.
And your clinic is pretty interesting. Tell us about what you guys do there.
Yeah, we try to take a very comprehensive approach. We have a brick and mortar kind of office location in Salem, New Hampshire. We see patients typically on a weekly basis. We do body composition analysis, lab work. We have a dietitian, a social worker. In addition to the medical piece, I'm a personal trainer as well, so I create workout plans for patients. We have a full food store here with 600 foods, so we actually give patients healthy meals. We try to really help patients make this a lifestyle that's sustainable and improve their health, of course, too. And the medications are a big part of that, and they're not mandatory, but they're an optional component that definitely can be assisting patients in their journey. So it's been great to see transformations. And I think part of the reason I'm so passionate is I see patients day in and day out who have transformed their lives and have lost 100 or even to over 200 pounds. And certainly the medication's not a cop-out. It's a tool in the toolkit, but it can be transformative for them. And I really, when I see patients crying tears of joy with how much this has transformed their lives, I will fight as hard as I can to help them continue to get coverage for things.
Well, so let's talk about the CVS Caremark thing. So we'll do a little bit of background. So if you're new here and you're just thinking about GLP-1s and you're like, what are they talking about? The higher level piece is CVS, the drugstore we all know and love that's in your neighborhood, is really a large corporation that owns CVS, that drugstore that you walk into, right? And that's one piece of it. They own another thing that's called a pharmacy benefit manager, one of the largest in the country, called CVS Caremark. Right. They also own an insurance company, right? So they own a lot of stuff. Yep. So the conversation today is about CVS Caremark and how they're covering or not covering Zepbound and what's happening. So that may or may not pertain to you. Tell us about that.
Yeah, exactly. I think that's an important clarification. I still see patients sometimes asking, does that mean I can't go to CVS anymore to get my prescription? And it doesn't impact the pharmacy at all. This is purely your insurance plan. Your employer is opted into a plan, and often that plan has a pharmacy benefit manager, which manages your formulary of medications, what's covered, what's not covered. And this can vary by employer, by state. There's a lot of differences, but the three big PBMs are Caremark, Express Scripts, and Optum Rx, and there's others as well. But of the three, Caremark is the biggest, and so their decisions have impacted hundreds of thousands, if not millions, of patients across the country here. And basically, a few months back, they decided to drop coverage for Zepbound and only cover Wegovy. They also will cover Saxenda and Qsymia and other instances, but their primary focus was dropping coverage for Zepbound and opting to prefer their coverage for Wegovy as their anti-obesity medication of choice, which at the end of the day, I think both medications are great. My goal is not to pick favorites and put one against the other. The goal is for patients and providers to have access to all the treatment tools that are out there, especially when you consider Zepbound is arguably the most effective medication, and trials have proven that. And so when we heard this news, it was just discouraging for patients who have had transformations in their life and their health. And there is no great rationale for why Caremark has done this besides purely cost savings on their back end. And we'll talk more about that in a little bit.
So just to clarify a little bit, because we'll get it. No, they haven't done that. I still have it. There are other comorbidities that you could be approved for. Sleep apnea is one of those, right?
Sure. Yep.
Type 2 diabetes, if you have Mounjaro. So there's other things going on. So this is really speaking to Zepbound to treat weight loss, obesity, the disease of obesity.
Correct. Yes, exactly. And not everybody who has Caremark is affected by this either. About 70% of the plans have the standard formulary, which is impacted by this. And there's probably 30% that have a custom carve out that's more unique to their employer. Perhaps they work for a bigger employer or state. And so not everyone's affected, but most of you who are aware of this by now probably received a letter from Caremark if you were affected, or your provider received a letter with all the patients. And I received a letter of, dozens of patients that were affected by this. And so basically, those are the people who are affected by this. But, I just recently typed an op-ed up about Blue Cross Blue Shield Massachusetts is dropping coverage for all anti-obesity agents in 2026. So this is not just a Caremark issue. This is a broad systemic problem that's affecting insurances across the country. We're seeing more dropping coverage than adding coverage. So we're going backwards here. And so Caremark is a big deal, what we're working on, but there's others at play here that are going to be affected by this too. So hopefully our advocacy can stem and build beyond just this one issue.
So, and I know you started a petition about this. Tell me about that. Yeah.
So as soon as the news hit about this whole Caremark issue, I kind of wanted to take a stand in some form and kind of stand for my patients. And I started a petition on change.org. And as of today, we have over 15,000 signatures for this petition. And it's basically just advocating to Caremark and their executives to consider reinstituting Zepbound on formulary as a covered medication for patients with obesity. And I made my points in terms of why that's the case, from efficacy to tolerability to indications and maintenance dosages and so forth. So hopefully it's certainly raised awareness. It's been featured in the New York Times. It's been featured in Bloomberg. It's been featured in many different publications and podcasts like we've discussed. So patients are definitely passionate, and they've left their comments on the petition and videos, and really, are trying to put the message across to Caremark why this is, not in the best interest of their patient base.
And I'll put a link in the description if you guys want to go participate, sign the petition. That'd be awesome.
Thank you.
The more people we can get speaking to CVS in that way, it's great. So obviously the shift over really just went into effect in this month, right?
Correct. Yeah. And that's a tricky thing. We've known about this for a few months, but Caremark has not given us any indication of who would be able to maintain coverage. And we've gotten different letters. Patients have gotten different letters. It's been very convoluted. And we knew that July 1st, this would all kind of kick in here. So certainly we've been informing people along the journey what's going to be happening, so they're aware of this. And hopefully people got refills in before the coverage dropped. But basically, we're in this scenario now where as of July 1st, anyone affected by this, now their prior authorization for Zepbound is basically invalid. Zepbound is considered a non-formulary medication. If you go to the pharmacy and try to fill it, they'll tell you it's over $1,000 and your insurance doesn't cover it anymore. What Caremark has done is they've basically transferred your prior auth for Zepbound to Wegovy. It's automatically covered, which is good. We don't have to do a new prior auth, at least not yet. And those patients who switch to Wegovy, their coverage will just continue automatically. Most patients may have a copay of $0, or if you don't, there's a savings card on Wegovy.com that takes off up to $225 off your copay. And so for patients who have insurance coverage, they hopefully will be paying $0 out of pocket per month for their Wegovy.
So how can a non-medical professional transfer a prior authorization? They're not a doctor. I don't understand.
This was all done behind the scenes from Caremark, basically. They basically can institute what's covered and what's not, and they just moved their Zepbound prior auth over, so Wegovy is now just automatically covered.
If they can write a prescription basically like that?
They're not truly prescribing it, but they're basically giving the authority for the prescriber to write it. So we still would have to write the prescription for Wegovy, but yeah, behind the scenes, the coverage is kind of now approved automatically in a sense.
Gotcha. So obviously everybody's been panicking and it's been all over the place, and for good reason, because a lot of people have been very successful.
Sure.
And there was they did a press release on it. They talked about it in their quarterly analyst call. It was a big deal. Now, I know the last few days, really since the beginning of the month, there's been murmurs about how it's actually rolling out and what you're seeing. So tell us what's actually happening out there.
Yeah, so myself and many other obesity medicine colleagues have been kind of, once July 1st hit, we were trying now to submit prior authorizations for patients to see how is Caremark going to play this game, and are there instances where they'll allow us to keep patients on Zepbound. Now, again, if somebody is, done well on Zepbound and wants to switch to Wegovy, and they've talked to their provider about this decision and feel as though that's a good fit, great. There are patients that is a great avenue, and I myself have patients that have made that transition, and we will hopefully see how things go and likely do very well. And so both medications are GLP-1s. There are intricacies and differences between the two, but both can be very successful. So the last thing I want people to do is worry if they are changing, because that's still a very viable approach and maybe very successful for you. But I have many patients that personally have previously tried Wegovy and either did not see as much success or perhaps had an intolerance to it because of nausea or vomiting or GI issues. Those are the patients I was the most worried about. How do I advocate to Caremark that this patient needs to stay on Zepbound because it's the best option for them? And so once July 1st came, I started submitting prior authorizations for those kind of top scenarios where a patient has history of intolerance to Wegovy. If Caremark's going to allow anything, those would be the ones you would assume that they would maybe cover. And initially, the first ones that I submitted were all getting denied. So I'm like, oh, goodness, this is not looking good. So then I called Caremark, and after waiting on hold and chatting with several people, I really tried to get up to the higher level and have a good discussion about what is their question set. And for patients unaware, a prior authorization is kind of this form that providers have to fill out either by hand or online. We use a website often called Cover My Meds that automates this a little bit in terms of giving us the forms. And we have a set of questions and criteria where we need to fill out and even upload documentation or chart notes to basically say why a patient is a good candidate for the medication. And that's what we do for all GLP-1s, unfortunately, so it makes it very time-consuming. But in this instance, I'm specifically trying to do prior auths for patients on Zepbound now that it's not longer covered. And the question set that it gave me, and I'm happy to kind of recite some of these questions so patients are aware. But they basically say, what is the prescribed product? We're initiating the prior auth for Zepbound, so we're choosing Zepbound. And then it says the patient's drug benefit plan provides coverage for other drugs, which are considered primary formulary options, and they list Wegovy. If you say yes, then you don't even need to do this form in the first place, because as we mentioned, your prior auth is already approved for Wegovy. And so your provider would not need to continue at this point. The prescription can just be sent over for that. Of course, figuring out the dose and shifting, that's its own discussion. But if we have an instance where a patient determines they need to stay on this medication, if we say no to that question, that Wegovy is not suitable, the next question says, has the patient experienced an inadequate treatment response, intolerance, or does the patient have a contraindication to Wegovy? If so, the provider must submit chart notes and documentation explaining the patient's inadequate response or intolerance or contraindication. And so if you say no to that, you're going to get denied, unfortunately. It's an immediate denial. If you say yes, then again, they're going to ask for your submission of documentation. And so I then started to type up letters for my patients and putting together the narrative of what they've tried, what their issues were, and why they're seeing success now and why they should stay on Zepbound. So after answering that chart note question, then the next question says, and this is the very interesting part, the patient's drug benefit plan provides coverage for other drugs which may be considered for treating your patient. Can your patient be treated with a formulary drug, secondary alternative, tirzepatide, in parentheses, brand Mounjaro? If yes, then the questions continue. Now, it even says here, tirzepatide brand Zepbound and tirzepatide brand Mounjaro contain the same active ingredient at the same strength and the same dosage. And so this is very odd. They're basically blatantly requesting an off-label use of Mounjaro for patients who are on Zepbound. Now, at the end of the day, yep.
So for those of you who may not, this gets kind of into the weeds on medications, but Eli Lilly, the manufacturer,
yep,
has the patent on tirzepatide, and yes, they do have a patent on tirzepatide. Sells medication, the tirzepatide, as one brand for the disease of obesity and a few other comorbidities called Zepbound.
Correct.
They sell the exact same medication, same dosage, same pens, just a different label, all comes out of the same factory.
Yes.
For type 2 diabetes and a few other comorbidities called Mounjaro.
Correct.
And those are FDA approved for those things. Now, the FDA doesn't stop doctors from writing off label. There's all kinds of medications that are used off label, but basically it's unusual for something like this.
Very much. Yeah. You said it perfectly. It's the same medication. So for those who are potentially switching, don't be alarmed. It's the exact same medication with a different wrapper on it. But as Christopher said, traditionally we prescribe the one that's FDA approved for weight management, and that would be Zepbound. And then the Mounjaro is traditionally used for type 2 diabetes. And just as a side note, if I initiate a prior auth for Mounjaro, and not through this whole Zepbound workup, but just straight up for Mounjaro, the question set that I would get are, does the patient have type 2 diabetes? And if so, we need proof of their A1C being over 6.5 or their glucose being above 126. And so it's a very specific criteria to get Mounjaro covered. That's why we typically can't get it approved for patients purely for weight loss. But in this instance, this workaround here, Caremark is actually basically requesting that we use Mounjaro instead of Zepbound for these patients. Now, I'll take a win as a win here. And if I can get the patient to get Mounjaro, that's going to be great because it's the same thing for them. But for CVS Caremark to be literally recommending and pushing an off-label medication just to avoid having to prescribe Zepbound is very unique. My hypothesis here is that they called Zepbound non-formulary. They refused to fill that. They're willing to do Mounjaro. Perhaps they've negotiated a better rebate, and they likely have because technically Mounjaro has been on the market longer than Zepbound in terms of its time. And so they may have a little bit bigger kickback on the behind the scenes here. So, of course, at the end of the day, it's all about money, and Caremark is probably saving money by opting to do Mounjaro instead of Zepbound. So very interesting.
Well, what it really tells you is the price of these medications is completely fungible. It can move wherever they want it to move.
Very much, yeah. The list price is not what these insurances are paying. There's a lot of middlemen and negotiations and kickbacks and rebates. So we don't even know what those real numbers are, but clearly Caremark has found a pathway here that saves them a few bucks. So
I'm curious. So because this is what you do on a daily basis, you guys' entire business is the treatment of obesity.
Right.
I know like drug reps will come in and talk to you. Do PBM reps, do you interact with PBMs or no?
Not really, no. I mean, I guess we interact with them when we call to do prior authorizations, which is a painstaking process. But yeah, there's no, person that we have a close connection with. Certainly when I email Caremark, most of the time it falls on deaf ears. It seems as though it's a painful process. And of course, different PBMs work differently and they all have their own questions. But they definitely can, muddy the waters and make this whole process complicating. And just think, every single patient that we want to try to get this approval for, we have to go through this entire process and write a letter and documentation, and it's no guarantee it's even going to be approved. And just to kind of continue that question set, if we say yes, that the patient can use Mounjaro here, initially, if you say no to this, again, you're going to get a denial. But if the provider does say we're willing to use Mounjaro, then interestingly enough, the next questions that Caremark sends are not diabetes questions, but they're actually more typical weight management questions. Will the medication be used with a reduced calorie diet and increased physical activity? Has the patient participated in a comprehensive weight management program that encourages lifestyle modifications, nutrition, and increased activity for at least 6 months prior to using medication? So these are often typical questions that we would see for Zepbound kind of questions. And then the one unique question is has the patient completed at least 3 months of therapy with the requested drug at a stable maintenance dose? And that's tough because technically they've been on tirzepatide perhaps for many months. but under Zepbound, not Mounjaro. And so in this question, you could probably go either way. But if you say no, because technically they were not using Mounjaro, then the next question set that comes up is asking for the patient's BMI. And they're wanting to basically see that it's either above 30 or above 27 with a comorbidity. Now, and very important to note here is that it is their baseline BMI. A lot of people worry, oh, my weight's now normal, so does that mean I'm no longer going to get coverage? Your provider must always document your baseline BMI prior to using any anti-obesity medications. And they even list that in the question here too. Please consider their baseline BMI at the start of any drug therapy when answering this question. And so if your provider puts in your current BMI as 25, they may deny that. You want to always document initial BMI in these instances there.
So for me, I started at 286.4 pounds. So my initial BMI, I don't even remember what it was. Let's see here, was 40.
There you go. Yep. 40.
Which will get you there pretty quickly. So essentially, my doctor needs to write 40.
Correct.
No matter how long I'm treating it.
Correct. That is your baseline, no matter what. And that's why we need to continue covering these medications, because we're treating something chronically, and we need to, just like if somebody had hypertension or had, any diabetes, if they had an A1C that was here or blood pressure was here, even though now it's normal, it's still controlled because of that medication's help. So we should document the initial criteria that qualified for it. So that's
these medications are not a cure; they're a treatment.
Exactly, 100%. It's a treatment for a chronic disease state. It's not to say that everyone is on these forever, but for a lot of patients, they may need that. And for a lot of patients, weight is this chronic, relapsing, multidisciplinary, complex disease state. And don't feel as though medication is a cop-out. It's a tool. And we wouldn't criticize a patient who is on an antidepressant and say you would stop it once you're feeling better, or a blood pressure medication. We wouldn't stop it once your blood pressure is normal. We're using this to maintain that success, perhaps at a lower dose, but just, it's a tool in the toolkit to continue alongside those lifestyle modifications. And so once we get through the BMI criteria, then at the bottom, it's basically just saying, have chart notes been submitted showcasing the patient's baseline BMI? So again, they need proof of these numbers. We can't just make up things. And then from there, the last question is basically, does the patient require more than 4 pens per month? And you need to answer no to that, because the dose is 1 pen per week. And so that would be, the indication and the amount. And so once you submit that, then comes the waiting game. Prior authorizations are no fun because you don't get an immediate answer most of the time, especially in this instance. So then you are now waiting for somebody at Caremark, and who knows what their system is, but to review this, read your documentation, and make their decision. Now, I'm happy to report that in these instances where patients previously did not tolerate Wegovy, or other scenarios which I'll mention, I have now had success getting a dozen patients covered for Mounjaro, and they can maintain their therapy, and they're very happy. And I'm glad that we got that win for them. Again, there are many patients that likely will switch to Wegovy and hopefully do very, very well, which is fine pathway for some. But if you are a patient that either has had an intolerance, a lack of efficacy, or have some form of a contraindication to Wegovy, then at least, share this video, share the, petition to your provider, and hopefully they can learn the steps to potentially securing a pathway for coverage. It is no guarantee.
So just to say that back to you, so an intolerance is nausea, diarrhea, or something so compelling that I had to stop taking the drug.
Exactly. More on the severe side for sure.
Yep. Or your second one is it just didn't work.
Right. Exactly. Yep.
Okay. And then, just making sure I understand.
Yep. No, those are perfect. And I'd say, other rationale, which I'm tinkering with and trying for some patients to see, and I've had a couple approvals, but it's still hit or miss, is other criteria you could theoretically come up with is that if a patient, let's say, has lost the weight and is now on a low dose of Mounjaro, either 2.5 or 5 for their maintenance dose, you could make the statement that Wegovy only has maintenance dosages at the top 2 of the range, and therefore there is no, for example, I have a patient lost over 100 pounds. They're now on 5 milligram as a maintenance dose for Zepbound. I made the very important claim to the insurance that forcing this patient to go to one of the top 2 dosages of Wegovy is not a good fit because of the fact that she's maintaining on a low dose. Zepbound is approved by most insurances for all dosages, or at least at 5, 10, and 15 as maintenance dosages, whereas Wegovy is only approved at 1.7 or 2.4, which are their top dosages. And so that's a potential pathway for some.
And so this is where Joe's in the weeds here on this, right? So this is
Exactly.
what he does every day. So let me repeat back and make sure I understood. All dosages of Wegovy and Zepbound are essentially the same medication. There's nothing special about any dose that makes it a maintenance dose.
Correct. Yep. But
However, insurance companies and PBMs, and even Lilly to a certain extent, have declared
correct.
certain doses are maintenance
Based on
doses.
their clinical trials. So the Surmount
Right.
trials specifically investigated 5, 10, and 15 for chronic use. So that's why they can call it a maintenance dose, whereas 2.5, 7.5, and 12.5 were like stepping stone titration dosages. And for Wegovy, they never studied the lowest 3 dosages long term. They were always used as a titration. So the only approved maintenance dosages are 1.7, 2.4. And some insurances hold that strongly when they're doing their approvals.
So there may be a slight technicality there for your doctor to say, hey,
Exactly.
my
I'd say
patient really needs this dose.
that one's a little more hazy in terms of if Caremark's going to take it, but I did have success with a very unique instance where that was approved. But I'd say your biggest criteria is typically going to be intolerance. You could potentially make the case, as you mentioned earlier, for sleep apnea, because that's a unique indication that Zepbound has that Wegovy doesn't. And lastly, I think the other instance which I may try is if a patient has lost a substantial amount of weight, above and beyond the averages, like 30, 40, 50% of their body weight. In the SURMOUNT-5 trial comparing Zepbound versus Wegovy, 25% or more weight loss was achieved by 31.6% of patients on Zepbound and 16.1% of patients on Wegovy. And so if a patient is looking or has achieved a substantial amount of weight loss, then the chances of achieving that are more than double the success on Zepbound versus Wegovy. And you could try to make that statement perhaps to Caremark. Again, they're not giving us any specifics as to what they're considering an intolerance or a contraindication or so forth, but these are just some rationale from my experience that may be worth exploring and investigating with your provider. But again, it's going to require documentation and letters and chart notes. And your easiest path, of course, to coverage would be to go to Wegovy. But if you have an instance where you did not tolerate it or one of these other circumstances, it's sometimes the squeaky wheel gets the grease and it's worth fighting for your coverage.
So if there are patients out there, viewers, who are seeing just a regular provider, right? My local family doctor,
Sure.
whatever, what advice would you give them? Because I can tell you, my family doctor had to hire a person just to handle prior authorizations for these
Yep.
meds.
That's becoming more common, unfortunately.
And I have seen other practices who just stopped writing it
Yeah.
because they didn't want to do all the paperwork.
Yep. It's hard. I think it varies dramatically from practice to practice. I've heard some patients that said, yeah, that my office told me that they won't get the prior auth completed for 4 to 6 weeks. I mean, I honestly try to do it as fast as possible for patients just because I know how important it is. And also, these medications require weekly injections. Missing a week can lead to side effects. Missing 2 weeks can require dose adjustments. This is something that time is of the essence here. So again, it's hard because some practices have tens of thousands of patients, and telling them you must do this letter for me is not feasible either. But I think at least giving your provider some actionable steps, if they're willing to take them, you can hopefully make a statement, especially if you are an instance where staying on the medication is potentially medically necessary. So there's a pathway there, but it's tough. Prior authorizations are just red tape that leads to more hassle. And just to put in perspective how crazy it is, when I submit a prior authorization and I get a fax back from the fax machine, 14 pages long.
An actual fax machine?
Actual faxes, yep. We're cutting down so many trees just to get these faxes, unfortunately, when this could all be done somehow. I mean, I submit them digitally, but they actually send the responses old-fashioned faxes. A denial is 14 pages and approvals about 5. It's, again, just insane. And there are instances where patients who should have qualified got denied, and patients you didn't think were going to qualify got approved. So it's no perfect science. It's a little bit of a work of art. And yeah, it's crazy.
Anyway, so there is a little bit of hope, right? There's a little window of hope that there's a possibility. I like that.
Yep.
You might want to send this video to your provider if they're open to watching something and might need a few tips on it. I think that's good. The other thing I would say is we have seen providers that just unfortunately are not as educated as they should be on this. If you go to our website, thedownsized.org, I have a link to find obesity certified medical professionals Those are people like Dr. Francavilla or Dr.
Mhm.
Soa. We've interviewed a lot of folks that are all certified in this, and might be time to find somebody who has a little more of an expertise in this. And you just need a little more help.
I agree. It's a complex field. The medications, the coverage is very hit or miss. And, a provider who does this day in and day out is going to know more of the intricacies to maybe get coverages approved for patients. And if it's not getting approvals, at least it's helping them transition to the other medication properly, getting their dosages adjusted. Again, there's no perfect transition here from one med to the other. So it's important to really make sure you're talking with your provider, figuring out the right place to be, making sure you're maintaining therapy. The last thing I want somebody to do is to just jump to the top dose of Wegovy and hope for the best. I mean, these require definitely some titrations here, and we want to mitigate side effects. So doing things slow and steady is a little bit safer for sure. If you are a patient that needs to fight for coverage, then use this rationale. But at the end of the day, the good news is we still have tools available to us. The pipeline is going to be exciting over the next few years with many other medications coming. Hopefully, as more options come out, coverage gets better and costs come down, and we can all, continue to advocate for why these medications are essential and why obesity deserves treatment just like any other disease.
Absolutely. I mean, I think that's the key is just as we get more tools that you can leverage, medication and food and all of these things, it's working with your provider to say this is a disease and I need to treat it. Now let's build a plan together.
Exactly. Very much so. It's going to be more personalized medicine in the future. We're going to have, different tools for different patients and not a one size fits all approach. And hopefully, we'll have oral options, we'll have monthly injections, we'll have, triple agonists and so forth. But for right now, certainly Wegovy and Zepbound are the most effective medications. And for patients to use these, it makes the most sense for a lot of people. But if you somehow have coverage for neither of these, don't lose hope. There are certainly out-of-pocket options through LillyDirect or NovoCare. There is also more generic medications, older medications that are available too. So there's a lot of options. So again, talk with your provider and go over everything and do your research. And hopefully these videos are great from the Downsized to continue to educate everyone.
The biggest thing, if you're thinking about doing this right now and you haven't started, first of all, go talk to your doctor, get your blood work done, get a physical, do all the things to do it. Second thing is I wouldn't panic over which drug you can take.
Exactly.
Both Wegovy and Zepbound are effective and have treated hundreds of thousands of people. Exactly. Honestly, I say, not a doctor, the best drug for you will be the one your doctor will write a prescription for and the one that your insurance will pay for.
I agree. I personally have had patients on both medications lose well over 100 pounds and have had excellent success. Their lab work has improved on both medications. They're both very effective, life-changing medications that have been shown to have benefits across the board, from cardiometabolic health to reducing risk for heart disease, sleep apnea. Some of these medications have some differences, but at the end of the day, if you have coverage for either, that is a success.
Absolutely. You won the lottery is what Lorraine always says. So.
It's true.
Well, very good. Well, thank you. Did we miss anything, Joe? Is there anything else you want to make sure you get in?
I think we covered everything pretty well. I think it just kind of helping people to understand the scenario. It's complicating, and hopefully this helped to shed some light on things. Hopefully the question set that you see, that we see on the back end, helps you to understand what your provider would deal with. Again, the questions are part of it, but the documentation is a big part of it. It's still very odd in how Caremark is basically pushing an off-label medication. We'll see the repercussions of that down the road. Hopefully, supply stays in good shape. Luckily, like you said, both Zepbound and Mounjaro are made in the same plant, so that should hopefully be easy to adjust. But I think at the end of the day, it's certainly a painful process. It's still frustrating for me. As much as I'm happy to see a pathway here, for Caremark to cause this entire mess in the first place is still infuriating, because at the end of the day, this leads to frustration and concern, and patients are not sure what's happening. And we have to contact each person, help them understand why we're either switching to a different medication or why we're switching to a different brand name of the same medication. And it just leads to more confusion. So I hope my video has helped to provide a little bit more information so people can feel more comfortable kind of continuing the journey.
Well, very good. So if you'd like to sign Joe's petition, I'll put a link in the description. Please do. Lorraine and I have both signed it. We think it's a great thing. And I'm sure Joe will be back to join us again. This is the third time he's been here. So
always happy to be here. Great discussions.
Absolutely. Thank you very much, Joe. All right. So if you haven't already, make sure you hit that like and subscribe button. We're publishing videos every day for crazy things like this. And, We believe in the medical treatment of the disease of obesity and you getting the tools you need to take care of your health. And folks like Joe are out there in the trenches doing it every day. So we appreciate you, Joe. Thank you very much.
Thank you. It's always an honor to speak with you guys. Thanks so much.
Absolutely. All right. My name is Christopher Durham for the Downsized. We'll see you next time.